Okay, let's stay on time and so we can start our industrial symposium or live and book session with Medtronic. The panelist here, Musa Akbar. نروح حق أدري. And Ahmed Emam will take us. Can you please sit down, relax, or go out and have coffee? I don't know what to say. اي يا حبايب يا بعد شبدي يا تقعدون يا تقعدون. You either sit down or sit down please يعني. We're going to start. We are late 3 minutes. So is Ahmed Emam. تعال حبيبي تعال. Kamal Ayub, Dr. Kamal Ayub, are you here? تعال بعد شبدي تعال قاعدين. Okay, so we have Dr. Musa Akbar, panelist. Dr. Ahmed Emam, you will take us through the evolution of renal denervation therapy. Then you show us a case. We'll be discussing with you as well, inshallah. I'll be your moderator.
Thank you, Dr. Abdullah. Thank you, Medtronic, for the invitation and be part of this symposium to increase awareness regarding this devastating disease, which is hypertension. So this is the population with hypertension. As you can see here from this recent publication, almost 23% of all women and 18% of all men, they have their blood pressure controlled to the targets level we suppose. And we know that can lead to increase the worst outcome, and it can increase the likelihood of having stroke, heart failure, coronary artery disease, and CKD as well. There is no question that the antihypertensive drugs are effective, available, and cheap, but the problem that the patient, they are not taking them as we wish. And this is an example of this from this meta-analysis, including patients with what we call resistant hypertension. As one of out of 5 patients, they are not taking a single tablet that we are prescribed to our patients, and almost half of our patients, they are what we call partial non-adherent to the medication, and that means they are taking one tablet and they're leaving other tablets, and of course we don't know which tablets or which drug are on board. Renal denervation is a new modality of treatment which can interfere and interrupt the bidirectional relationship between the brain and the kidney. And if we can do this effectively, we can really decrease the signals between kidney and brain. This is the evidence we have regarding the RF renal ablation. This is a spiral program. We have off-med trial, on-med, and we have JAZI-SR registry. Off-med naive patients not taking any medication, on-med patients on medication, at least 3 medication, and registry to show us the real life of our hypertensive population. And this is the result of our off-med population. Really, the good things for the renal denervation, it's always on procedure. So it doesn't matter, you are eating, you are walking, you are at work, at home, your blood pressure is controlled all over the 24-hour a day. So this is the good thing about the renal denervation. And this is also true about the other population on drug therapy. So as you can see here, there is no matter if you are taking medication or if you are not taking medication, your blood pressure will get to the target level. And the good thing also, this is the 3 years follow-up from the Ahmed trial just published a few months ago. And it's not only your blood pressure is going for a short follow-up, 3 to 6 months, no, but it's up to 3 years. So the effect of renal denervation, it's consistent and it's also incremental. So your blood pressure will be, for your patients, will be on targets up to 3 years follow-up. The number of drug also will be decreased at 3 years follow-up with mean drug numbers reaching 7 versus 10 for those who are not go for renal denervation. So the number of your population, this is the result we have from the Ahmed follow-up 3 years. Doubled number of your population will be controlled versus the population only taking medical therapy. And this is also same data we have from the registry, the real life, same reduction of blood pressure over 3 years follow-up. This is the 2021 recommendation from the European Society of Hypertension, the position paper. I will just read it as it is. In light of the second generation sham-controlled, randomized controlled trial, it's now established that renal denervation reduced consistently blood pressure across a variety of hypertensive patients with mild to moderate hypertension. I need only 1 minute before we go, okay? More severe hypertension, both in the presence and absence of concomitant antihypertensive pharmacotherapy. This is also the data we have like 2 months ago from the European Society of Cardiology, the position paper on renal denervation. We have this data regarding the efficacy, safety, and who should be considered for renal denervation, adult patient, uncontrolled resistant hypertension, at least on 3 medication with eGFR more than 40 millimeters per minute. Thank you very much. And now, Dr. Musa, I think we can go for that. Okay. Okay.
So now you will take us through the case?
Yes.
Great. So 1 million been affected, oh sorry, 1 billion, more than 1 billion been affected by hypertension. And we know like 9 million dying from this lifestyle medication, not enough. And lots of evidence now coming from randomized clinical trial of this tool. I think many centers, I think all of you are doing this now. Many centers become interested in this tool. So we're going to see a case live in box, how to do this. يلا يا حبايب.
Good afternoon. Welcome to Sheikh Hospital. Today we have interesting renal denervation case for a patient with refractory hypertension. I'm here with my friend and colleague Dr. Ahmed Al-Faraza. We'll perform this denervation case using Medtronic spiral catheter. We'll mention some advantages and merits of this system and take you through the case we are going to perform today. So let's start with case presentation.
So today we are presenting a 45-year-old male who is known to have type 2 diabetes, dyslipidemia, previous PCI to the left circumflex, and the long-standing uncontrolled hypertension, with an average of his blood pressure of 160 over 100 with normal creatinine and normal eGFR as shown in the slides. He is also on the current medication, which include aspirin, Crestor, and good doses of 4 antihypertensive therapy, which include perindopril, amlodipine, thiazide diuretics, and bisoprolol. And his ECG shows sinus rhythm with LVH, with an echocardiogram that showed normal LV function with septal hypertrophy and mild diastolic dysfunction at grade 2.
Let's talk a little bit about renal anatomy and catheter-based ablation, as that has been changed over the past few years with the better understanding of how we could approach this technique. As earlier we thought that the sympathetic renal nerves are mainly around the proximal and mid part of the renal artery. But now with pathological specimen, we know that the renal nerves are mainly around the distal part of the renal arteries and around the branches and even in sub-branches. So that led to change in our understanding and using renal ablation with targeting small vessels and branches. Previously we didn't ablate with renal denervation therapy. So now with only one size Medtronic spiral catheter, we could ablate and confirm any extra parenchymal vessels between 3 to 8 millimeters in diameter. Let's move to the catheter. This is the spiral catheter we are going to use today with mainly 3 key components. It has a special spiral shape and with soft achromatic tip with 4 electrodes on its surface for ablation. The recommended wire we are going to use should be a non-hydrophilic wire with floppy ends and quite supportive shaft. And today we are going to use the IM guide catheter, 55 centimeter in length, but also we could use JR catheter or RDC guide catheter up to 90 centimeter length. So now we start our procedure with abdominal aortography, and Dr. Ahmed will tell us why we usually start our procedures with abdominal aortography.
So we start the procedure with abdominal aortography with a pigtail to make sure that we are not missing an accessory renal artery. And usually if it is above 3 millimeter, if we find an accessory renal artery and it's above 3 millimeter in diameter, it should also be ablated.
And luckily here in left kidney,
Yes.
it seems we have accessory renal artery. It seems all between 3 to 8 millimeter in diameter. So branches and main arteries seems to be suitable for ablation today. So after getting the catheter out of the package, we'll slide this orange straightening tool down to the spiral catheter here, so just to make it more straight and be easier to load it over the wire. So after the wire exit the rapid exchange ports here, so we'll take it back to its original place.
So it doesn't get caught with the wire.
So now we are introducing the spiral catheter over the wire, and it can track the wire, as you can see here, really easily. And now we already wired the accessory artery in the left kidney, and now we are introducing the catheter just to the site we need to ablate. So now we are happy with this position. This is the screen of the simplicity generator, which will control the ablation process. The impedance screen will display once all 4 electrodes are out of the guide catheter, and the 4 white lines here representing the impedance value, which if stable means adequate wall contact. And this is the remote control of the generator with 4 buttons here, 1, 2, 3, 4. 1 is for the very distal electrode and 4 is for the very proximal one. We can control the electrodes using these buttons. We can select and deselect any of these electrodes at any time. So it's not necessary to use all the electrodes at a time. We could choose between the electrodes according to the anatomy and the area needs to be ablated at this time. So now I'm going to start the ablation by pressing the RF buttons here. There is 3 important parameters to be noticed during ablation: temperature, impedance, and time. Temperature should rise up during the ablation, impedance should drop during the ablation, and time, it's 60 seconds for each ablation cycle.
Here we had one electrode that became faulty. It's probably due to a movement in the electrode and loss of contact.
After this ablation cycle, we'll reintroduce the wire again just to undeploy the catheter, and we'll take it back a little bit just to ablate the 2 other sites we didn't ablate before.
So it will be electrode 4 and electrode 3.
Basically, there is no any action is needed during the ablation, but only if needed, we could afford the ablation procedure by pressing the RF button again. It seems now we have a successful ablation cycle here for this artery. So I'm going to introduce the wire, and I retract the catheter back to the guiding. Then I'm going to engage the main renal artery here. So we'll rewire this artery, and we'll reintroduce the spiral catheter here just to be sure. Yeah, it seems a good position here, Dr. Ahmed. So
Let's do a cine.
yeah, let's go with Sini. Okay.
I think this is perfect.
This is perfect. So I think we can go with the 4 electrodes in this site.
So we will not deselect any of the electrode. We'll keep them all 4 at the green level, and then we'll hit a radio frequency ablation. It's very
So it's not recommending to ablate at the site of bifurcation, and it's not recommending also to ablate same spot twice. So this is the check status condition, which occur when the generator detects a treatment condition outside its acceptable range. So for example, if the temperature is going too high and if the impedance is not enough, the corresponding electrode will shut off at this only electrodes, and the ablation, it will carry on with the other electrodes. This is a safety measure and to ensure better ablation energy. So now we are done with this part of the vessel. Again, we'll introduce our wire, then we'll go back a little bit here. We'll check our position again. Yeah.
So we will ablate at 2, 3, and 4.
Yeah, exactly.
So we will deselect one, take it out, and then we see that the impedance is good, and we will start radio frequency at 2, 3, and 4.
Now, after we are done with ablation of this main artery, again introducing the wire, redeploy the catheter, we'll get it back to the guide catheter. Then we'll take angio just to be sure everything is fine. There is nothing, no spasm, no perforations, nothing. So I think we are done with this main artery at this stage. After we've done with the case, we have here the treatment summary. So we have all the information we are needed, so we can have the procedure time, impedance, temperature rise, and we can get all the information over the USB and use it for data analysis later on. So we are done with the case today, and thank you for being with us at Chest Disease Hospital.
Okay, Thank you very much. I don't know how long we have. 2 minutes, 3 minutes? Let's discuss this case. Anyone from here, expert in the renal denervation, you want to have a comment? I'll go to the Musa.
Ahmed, thank you very much for this nice presentation and case demonstration. What is the question? 2 questions. What is the expected blood pressure decrease, and if the patient have a failure in the few months back again to uncontrolled, would you repeat the procedure?
Yes, short answer regarding the first question. Short-term follow-up, we expected to get blood pressure as lower to 10 millimeter systolic pressure, diastolic pressure down to 6 millimeter. In the long-term follow-up, up to 3 years, we expected to get pressure down up to 20 millimeter office systolic pressure, 10 millimeter for the diastolic pressure. For the second questions, actually, we don't have that enough data to support denervate the patients again, but in the registry and from our experience, we did re-ablation of some few cases, and we got really promising results.
Thank you. Your second question has been answered?
I have only one comment just to add regarding the analgesia and anesthesia. This procedure is really, in comparison to the previous Flex one, it's really, the pain is not that much, so no need to over-medicate your patients. Only few analgesia and anesthesia is enough for your procedure.
So over 1 decade, we've seen the safety and efficacy of this procedure, whether it's radio frequency or the ultrasound.
Exactly.
The question remains is who are the ideal patient for this RDN, to start with?
Yes. The ideal patient for current data we have is the true resistant, uncontrolled hypertensive patient. Patient at least on 3 drugs, antihypertensive medication, one of them should be diuretics. His blood pressure is not at target, and pseudo-resistant causes should be excluded, like white coat hypertensive or whatsoever, and secondary causes should be excluded. This is the ideal patient supported by data. There is some other patients, it can be included also, like patient non-adherent and patient preferences, for example, but the data is support only the resistant hypertension uncontrolled patient for time being.
So, great, actually, case. I just want to ask, usually, having the pool of patients that actually you need for this procedure is very important. So how did you manage to create like a hypertensive medication, hypertensive clinic or resistant hypertensive clinic, and whether you actually follow up your patients in this specialized clinic, or what's your setup? It's very important for the beginners.
Thank you for this great question. Yes, it's about how to create a hypertensive program. When we started, the procedure itself, it's easy to proceed with. It's not that complicated. But the issue, how to create a hypertension program at your hospital. So we have in our center, Chest Disease Hospital, we created a hypertension clinic. We get referred patients from the other hospital. We have like checklist program and how we can exclude secondary hypertensive causes. Our physician and staff, they got trained about how to deal with these patients. Then if the patient is uncontrolled, if he is eligible for the denervation, then will be referred to us. But it's all about the hypertension program, of course. Yeah.
Great. Yeah, I'm sure everyone's hungry now for food, inshallah, lunch time. Thank you very much, Ahmed,
Thank you.
Medtronic, and the panelists. Thank you.
Great.